North Carolina. Dr. Zenn is a plastic surgeon. Says go live. Yes, we are live. Dr. Micheal Zenn is a plastic surgeon that a friend of mine introduced me to a couple months ago, and he is a brave doctor. But today we really want to talk a little bit about COVID, how it's impacted plastic surgeons' practices, as well as just questions women may have around nipple-sparing techniques and delayed in reconstruction versus immediate. But I really want to give a little background on Dr. Zenn. He's got quite the background. I looked him up. He went to Brad and Cornell. He went to Cornell for med school, and he also did his residency training at Harvard, Mass General, a fellowship at Memorial Sloan Kettering. He's been on faculty at UNC and Duke. I think he's trained a lot of my good friends, so I'm really honored to have Dr. Zenn join us. Hi, Dr. Zenn.
We're a small group of people. Christine, thank you so much for having me, and it's always been so much fun talking to you. But I'm excited just to share some of the stuff that we're doing. COVID is really, it's certainly a once-in-a-lifetime kind of thing for us, I tell you, and it's been hard from a standpoint of any of the cosmetic portion of our practices has basically shut down. It's felt not to be essential, and plus, like, there's some serious disease going on, and people really have more important things they're thinking about. Breast cancer does not take a break, unfortunately, and we have seen women who have been unable to get mastectomies because of rationing of care and just getting lumpectomies and kind of holding off. But I think, at least in North Carolina, and I know in a lot of my friends throughout the country, you know, we're back at that point where mastectomies are now possible again. And there are still some people being rationed, saying, have your mastectomy and just wait on reconstruction later when we have time, which is a big advantage of my technique as well, because, you know, you're done with your reconstruction within 2 weeks, and there is no later on. There's only that reconstructive surgery. So,
it's an elective procedure, Dr. Zenn, correct? They're deeming this type of surgery elective. Is that correct?
Most hospitals that I know and the ones that I work at have different criteria for surgeries that like have to happen within 1 to 4 weeks are now like the top priority, obviously aside from emergencies, but with like cancer patients, anything that can wait longer is now on hold, you know, and as there's less and less patients with COVID, as more and more ORs open up, those patients will be allowed in. So people putting off maybe joint prostheses, things like that, are still being held. Someone who's had a mastectomy, we can still get in though and do their reconstruction, put an implant in, and that's still felt to be a priority case right now. And I think largely because we just haven't been overrun, at least locally, with a lot of COVID patients. So,
are they? I've heard from different surgeons. Actually, Dr. Firmani knows you, and she said in San Antonio there's different tests.
Gina's a good friend of mine.
Yeah, she adores you.
One of my trainees, but she's awesome.
Yeah, she said that in one hospital there's no COVID testing, and then every hospital has different types of COVID testing. I don't know if you've experienced that.
You know, I think the issue is the same issue you've heard in the news all the time. There's just not enough tests. So, you know, there will be a point where every surgical patient will need COVID testing. And right now it's 48, 72 hours before, because we need that test to come back. That's usually a swab of some kind. A lot of private practices, a lot of smaller hospitals, if they don't have the tests, are right now doing temperature and questioning. But I think the standard will very quickly be COVID testing itself, just because if you have an active infection or if actively shedding the virus, you know, you shouldn't be having surgery. Like, you should recover, or potentially you're going to be sick and recover, because think of all the problems that would be. Now you're post-op and now you're hit with a respiratory infection. It could be devastating.
Yeah, if you're immune compromised anyways.
Yeah, and it protects the staff at the hospital and surgery centers as well. But, you know, this happened early in my practice, was when HIV was a big deal and everybody was freaking out. How are we ever going to take care of patients again? And what we learned from that is you treat every patient as if they have HIV. And my attitude is, like, every patient is a COVID patient and maybe shedding virus just because they don't have symptoms. And we have to do whatever we can to be safe. And so certainly, you know, if we can swab somebody and then they can think about it, even for that 48 or 72 hours, they have to basically quarantine, right? Because if you get tested, you're negative, but then you're going out and doing stuff, you can still come to the hospital.
Right.
There is no perfect. You know?
I never thought about it that way. That's something we should do another series on, because if you treat everyone like HIV and the same for COVID, and
universal precautions.
That's really smart.
For patient safety, we can check ahead of time, because an active respiratory infection might be different than getting like a hepatitis C or an HIV, where there's more long-term consequences. They probably could still have surgery safely. So
Well, I love everything you're saying. I want to talk a little bit about. We had a patient come to us with Brave that the doctor wanted to take her nipples off immediately. We referred her to someone else. She wasn't a high risk patient, so she ended up getting to keep the nipples. But I know you've created a procedure that is actually called staged immediate breast reconstruction.
Correct.
So when I read your paper this morning, it's we'll send the link out to people if they'd like to read it. It's through the Plastic Surgery Reconstructive Journal, which is a great journal. So maybe
It's a little light reading.
it was light reading for me. I enjoyed it.
Yeah.
But maybe you can kind of get it down to like every consumer could understand it. That'd be great.
Sure. And I think, once someone's diagnosed with cancer, they suddenly have to become very knowledgeable in this. And most people don't really understand a lot of it. So I think a lot of mastectomies used to be just removing the breast tissue and removing the nipple and the skin, because the nipple was thought to have breast tissue in it. And that was just the standard. Everybody would be flat. If you wanted a reconstruction, we would put a balloon in and stretch the skin out and do an implant reconstruction. And then, I think the Europeans have always led the way on this, but, there really is no reason to remove any skin. And in fact, if the tumor isn't right near the nipple, you can easily save the nipple as well. Anatomically, it's a safe thing to do. And there's been enough studies now that have shown that patients don't get recurrences in the nipple themselves. So, and it turns out that if you can save your entire skin envelope and save the nipple, you can get a beautiful reconstruction. Sometimes it almost looks like an augmentation. And in fact, that should be the standard. And now that a lot of our patients are getting BRCA tested, or they have a really strong family history, they're having a preventative mastectomy. So like, why would you take out the nipple and take out all the skin? So now even more so, the pressure's on us to do that for patients and do it safely. The big problem, the blood supply to your skin and the blood supply to the nipple comes from that breast tissue that you just removed. And we've done angiographic studies. We can look in the OR and see that what happens is you get a lot less or a lack of blood supply in the area where the nipple and that skin is. And what happens is that skin will, in a percentage of patients, will go off and literally can die. And so you can lose the nipple. And there are papers that show it's as high as 40% in some places, where 40% of their patients were having skin necrosis and nipple necrosis. And so the safer thing to do was just to put a tissue expander in and don't try to do any of that. But one of the basic principles of plastic surgery I will not claim to have created is that when tissues don't have good blood supply, if we can kind of just leave them alone and just don't do anything with them, the body naturally will regain blood supply, will reconnect capillaries, and will strengthen that area. And generally we do this in reconstruction all the time. It's never been applied necessarily to like mastectomies, because immediate reconstruction has always been at the time of the mastectomy, do something right then and there.
Yeah.
So we're calling it a staged immediate. It's a little confusing. In fact, a lot of people in the country were calling it a Zenn delay since they knew it. So we adopted that name because it's just easy to remember, Zenn delay.
Yeah.
But it's basically saying, let the surgeon do the mastectomy, and then you're done with that surgery. They'll put a drain tube in, go home. It turns out mastectomies are not even that painful. Now, when we start putting balloons on their muscles and changing things on the chest wall, it can become painful. Let it sit there for 2 weeks. And so you'll have a collapsed skin envelope. What's happening during that time is you're not doing anything, so the skin can get super strong. And then what I do is I go back at 2 weeks, again, outpatient surgery, go through whatever incision the mastectomy surgeon made. We're looking at the nipple, we're looking at the skin, and you can put a final implant in. In fact, patients will come to my office at a week, their skin is collapsed, and we'll try on different size implants in their bra so they can actually choose what size they want to be, which has never been really possible.
That's unbelievable.
Before we kind of just stretch the skin, it kind of looks like a breast, we're not sure. And then in the OR, the surgeon makes that decision.
Yeah, and I know you prop them up and try to see what it looks like, but it's hard at that point. What about the nipple sensation? Does that impact anything, Dr. Zenn, when you wait like that?
So it really doesn't, because the skin is completely numb after a mastectomy.
Okay.
And what happens is all those little nerve endings that normally are running up to the skin will eventually grow back. And it always amazes me, even with tissue expansion under a muscle and a big implant, that if you wait long enough, people will regain some sensation. It's not erogenous sensation, but it's like, I feel that feels sharp to me in a large percentage of patients. But the helpful thing, honestly, is that, because the skin is so strong at 2 weeks, we can put a bigger size often than the patient had. So we can go a little bigger if they want to. And oftentimes, hey, why not? Take the advantage. You're going to have a mastectomy. Let's make something good out of it. You always want it to be bigger. And you also don't need to use their muscle, because the skin is so strong. We support it with an acellular dermal matrix, which happens, it's a material we use even when we put it under the muscle. So that's not anything that's new or different. But you can actually be relatively pain-free with your second surgery too. But the key is that at 2 weeks, you're done.
That's
And so
wonderful.
actually it's become the procedure of choice for me, for women who are, we know you're going to get radiated.
Yeah.
Tumor's large enough. It's maybe we know it spread to the lymph nodes. It used to be, don't do reconstruction, come back in 6 months. You'll need a flap tissue. You'll need to do something. But actually, if we know you're going to get radiated, radiation starts at 5 or 6 weeks or so after the mastectomy. We're doing your surgery at 2 weeks. And that implant, that final reconstruction can get radiated and do better than having a balloon or a tissue expander that's in there. Now it gets radiated. Now I have to go back and do another surgery in this irradiated field. My options are limited as to getting a good size. And also the complication rate's a lot higher. And there are a couple other really cool benefits that we hadn't really thought about. Number one is that because we're not doing any reconstruction, we actually get the pathology back at a week. And so if there's a positive margin, if everybody biopsies under the nipple, if there is a concern with the nipple, like we haven't gone and lifted the muscle up or done anything else that potentially would spread cancer. And, that's one advantage. Number two is that, because the scheduling issue, now your general surgeon, if you do a mastectomy, it may take them an hour and a half or 2 hours, and then you go home, and then you schedule me, and the procedure is another 1.5 or 2 hours to go home, versus having to schedule a time to get the two surgeons together. I can tell you as a plastic surgeon, going in 2 hours later to put a prosthesis in is kind of scary because of all the bacteria potentially that have gotten in there just over a period of time, where the skin is swollen now, or there's been bleeding already. And so it's nice because at 2 weeks, your body's natural cells are healing like crazy, trying to heal this because they think it's a wound. The skin's trying to stick down. It doesn't stick down at 2 weeks. 3 weeks, 4 weeks, it'll be stuck down. So it's a window of time where now it's completely sterile again. Your body has cleaned it up. There's new blood supply there, and the whole reconstruction integrates really, really well. So, there are people, and I pioneered some of this at Duke, where we can use technology to look at blood supply in the skin. So at that first operation, at the time of mastectomy, look at the blood supply, make a decision about putting an implant in right away. And the issue has always been a frustration of mine, is that technology is just not available to many surgeons right now. And there are a lot of companies that are trying to improve that. So
the angiography that you mentioned, is that not working, or you use something else? Did you say?
Say that again.
What are you using to look at the blood supply? I didn't catch that.
So when I was at Duke, we used the technology. At the time, it was called SPY. It was a company, Novidac. It basically is an injection, and you look at blood flow in surgery. And there are many other companies now. QMI is a company that has the technology as well. It's all based on this blood supply, which again, it's not foolproof, but it's a way. Certainly at a big academic institution, some have this now, but a lot of us in private practice don't have it yet. And that would be a way of potentially doing it all at once. And one of the other advantages that we didn't really quite predict is that we know, and I know from my own experience, when we put an implant in, even with angiography in a mastectomy, because it's a fresh wound, it's just getting started, it takes about 2 or 3 weeks for the tissue to grow into that acellular dermal matrix material. So drains are going to be in for at least 2 weeks, and in some studies 3 weeks. It's a risk for infection. And so the patient's moving around. It may never incorporate or cause a problem. Because we're waiting 2 weeks, all the healing cells are already there. The new blood supply is already there. When I go into this wound and kind of pick the skin up to put the implant in, it's already has fibrin. It's kind of sticky. When we put that acellular dermal matrix in, it grows in, it adheres and grows in almost immediately. And so drains are in for like 3 days. So there's another 2 weeks, 3 weeks of drains. And if they're doing tissue expanders, I love telling patients, I see them at 2 weeks and they're done. And we're like, okay, everything looks great. I'll see you in 2 months. I said, you realize right now you'd be starting tissue expansion, and you'd be going through 2 or 3 months of expansion and then need another surgery. And they're like, oh my God, thank God I didn't have to do that.
And that's so much
the standard. The standard is, what does everybody do? That's the standard. And so we're trying to change that. I think this is a surgery that any plastic surgeon really could do, and it will be the standard. I am convinced of it. Just in a matter of how long a time is the question.
What we'll do is we'll post this on all the channels we have, Dr. Zenn, because I'm thinking of it not only from your perspective, the clinical and all the benefits there, but we're also hearing patients cannot get that coordinated care from the breast surgeon, the plastic surgeon. And so, and if you're out of the network and the other surgeons in the network, it gives them a little bit more flexibility to pick, the plastic surgeon they want to.
And that is huge, because there are people in underserved areas who just don't have access to plastic surgeons. They'll find me online. They'll be like, I really want to do this. I was like, great, listen, stay in your community. use your general surgeon, your oncologic people are there, your radio, like whatever you need. You're going to just be coming to me for reconstructive surgery and getting. So I used to be at a big center like Duke. They would have to change their doctors, bring all their care over. So it was one big team, and team care is really important. I think that's a good idea. But honestly, if you're not near a big medical center, sometimes it's just not even practical. Now, patients are empowered to find their surgeon. And you can pick whatever plastic surgeon you want. Like, I love my general surgeon. This is the person I want. Maybe don't love the people that I've seen for other surgery, or maybe they didn't even talk about reconstruction.
Right.
And it's confusing to the general surgeon, even if they've never worked for me before. I said, do your mastectomy any way you normally would. Put a drain in. That's all you need to do. I'll take care of the patient from there.
That's weird.
Surgeons really like that too, you know.
I'm fascinated by this. I'm definitely Brave's going to try to get the word out, Dr. Zenn. We'd love to have you on again. We try to keep these to 10 to 15 minutes. So what we'll do is we'll send it out, probably get some questions, and we'll have you come back if you'd like to. And hopefully next time we do it, I won't have a 5-year-old in the background making noise. I apologize.
Yeah, I mean, put my email address and my website in your thing. I'm happy to answer anybody's questions. It really, we have a little bit of time now with COVID, you know.
Yeah.
You know, so we're hoping to. We've been doing some reconstructive stuff, not that much cosmetic stuff. Hoping to get back soon, though.
Hope you go back soon. But thanks for being on. We'll talk to you soon. Thank you.
Oh, thanks for having me.